hole forms. The same patient recently, this last month, is a lawyer in Delhi. She came very disturbed that she doesn't want the surgery, but her profession is insisting that she can't see properly. And she's developed a vitreomacular traction, and then it's torn off the inner retina, and soon within less than 2 weeks she came back with the full thickness hole. So it progressed very fast. So we got pictures of all her, and she's still waiting for her surgery, but she's still not convinced what's going to happen because of the these lawyers. So what I personally feel that the least diameter is C, and the macular hole index is if you have the ratio of the height of the hole upon the base. So height of the hole upon the base, we do it for all our cases. So if the height of the hole upon the base, if the value is taken, it's called B over A. This is reported in AGO, and this B over A, if it's more than 5.5, it indicates a better prognosis, while low MHIs result in more failures. And the smallest diameter, less than say 500, is also supposed to be 500 microns, is supposed to be better chance of closure. So see few small things that macular index of greater than 0.5 improves hole closure, type 1 closure you get. And second thing was that visually, this is the morphologic or the anatomical recovery. We were just discussing about the ellipsoid band. The ellipsoid band integrity is also plays a role for the functional recovery. And we did a study where we found we put in various predictors or factors which could help in the hole closure finally, and we found that the size of the peel also made a difference. And then I'll come to the dyes and drugs quickly. Infracyanin green has come in. It stains the ILM and peels very well. It's supposed to be a non-toxic dye. Contains no iodine and there's no sodium in it, and it's diluted in 5% glucose to obtain an isoosmotic concentration. We still probably don't have it here, but Brilliant Blue G is available off-label. I'm talking about it off-label because right now we've just gone through a very bad Avastin phase, which we thankfully is getting over, in which Ajay also played a major role, and it's a very effective ILM stain. It stains the ILM but does not stain the epiretinal membrane, and it was talked just now that the epiretinal membrane is actually a negative stain. So the ILM is seen, blue ILM is seen if the portions is visible against a non-stained ERM. This is just to show that Brilliant Blue G was more effective than steroids. The rationale for surgical management is mobilization of the hole edges by removing all this ERM and ILM around the hole, all the tangential AP traction. Then this automatically activates at the edge of the hole glial cells by vitrectomy and the epiretinal peeling. These glial cells then proliferate in a centripetal fashion towards the center to help the hole closure. Third factor is the immobilization apposition of the hole edges by gas, which helps. Besides the glial formation and proliferation, this apposition occurs because of the traction has been relieved, that hole edges tend to slip together by the gas and the face down positioning. This has been the classical teaching all along. So larger holes still pose a surgical challenge, and less than, as I said, the smallest diameter, this is the smallest diameter being talked about everywhere, is 500 or 400 they have mentioned. It should end up as larger than 400 microns, end up more chances a failure or a type 2 hole which is a flat open, means the hole hasn't closed but the two edges are flat. So we published this data and presented in APVRS Hong Kong that we tapped the hole edges to increase the height so as to increase the macular hole index. But this is just to tell you what. Recently this year we sent this paper for publication, which we're doing a inverted flap surgery for macular holes, and we're doing multi-layered versus a single flap. Compared to conventional inverted flap, that is a single flap. So we put multiple layers of the ILM from all sides for large holes, and this has gone to the graphics, and we found the multi-layered flap had a better post-operative visual outcome as if taken in the logmar visual acuity as compared to the single flap inverted ILM peel. And so we chose the worst cases for multi-layered flap. And this paper, this is just to show you flap which has been created. This is a Brilliant Blue G stained, and this is how we just create the flap over it. And this is we have the IMI OCT guidance, which really comes in great use. The corneal surgeons use it and so do we. And you can see the flap bridging the hole. It literally closes the hole. So that's a big thing. And even after gas injection using the Recite on the Zeiss, I make sure that the hole is closed. I'm doing this kind of a flap on the pit cases also. So I will skip this video, and this is just to come to a traumatic case we did recently 2 weeks back. Again, he was a case which had a large hole. His distance of 1449 base, very high, very large base. Base is large, it generally doesn't come out a very good option, the surgical option, but he's cleared. So the inverted flap, multiple flap. So you can see these remnants of the flap. These remnants get engulfed by macrophages over time, and the patient vision really improves. These flaps don't interfere with the vision. So we're getting some very exciting results, and practically a day will come where we don't need positioning was. And I just want to ask you a question in the end of my lecture that audience, why do we peel ILM in macular surgery? To ensure removal of any tangential and tractional components, epiretinal membranes and glial cells, or is it to promote glial repair by inducing local expression of growth hormones, or is it to, number C is to reduce the possibility of reopening of surgical closed holes by removal of a pre-retinal scaffold for reproliferation of myofibroblasts? Which one? All of the above. Yeah, that's correct. Thank you so much. That's all.